All right, let's go. Let's go. Come on, we got to hustle. Let's make some rounds. Lee, you're on the service again?
Yep.
Okay, well. All right, let's hear the story. Ann, welcome back.
Thanks.
Yeah. How was pathology?
Excellent.
Yeah, good. All right. Go ahead, Kathy. Let's hear about this patient.
All right, so this is also a Miss Lee. She's a 17-year-old woman that came in complaining of abdominal pain. So she was well until about 24 hours ago when she began experiencing lower right quadrant abdominal pain. The pain doesn't radiate, doesn't go anywhere. Onset was insidious, became worse. She hasn't been hungry at all. She endorses fever, but she doesn't have chills or sweats. She doesn't have any pain around her umbilical area. She last ate about 24 hours ago when the pain began. She is still having flatus, but has not had any nausea, vomiting, constipation, or diarrhea. She doesn't have any problems with urination. She last had her menstrual period about 2 weeks ago, and she denies any sexual activity in ever, and she has no episodes of abdominal pain like this. She doesn't have any other medical problems. She's never had surgery before. She does not take any medications, and she's not allergic to any medication. She doesn't have any significant family history. They don't have any abdominal problems, no cancers, no cardiac issues, no problems with anesthesia. Social history, she's originally from Hong Kong. She speaks Cantonese only, but her sister is here. Her parents are still in Hong Kong, but she lives with her sister, and she's able to take care of her. She does not smoke, drink alcohol, or use any other illicit drugs. Review of systems was significant, as stated above, and otherwise negative. Her vital signs, she's afebrile right now at 36.8. Blood pressure was 107/68. Heart rate 72. Respiratory rate 18. She was satting 100% on room air. She's a really slim young woman lying really still in bed. Doesn't look like she's in any acute distress. Head, neck exam were without any notable findings. Her lungs were clear to auscultation and auscultation bilaterally. No wheezes, crackles, or rhonchi. She had a regular rate and rhythm in her heart, no murmurs, rubs, or gallops. Her abdominal
You can just tell me about her abdominal exam.
Okay.
If that other stuff's normal, just you can tell you.
So her abdominal exam, she had a non-distended abdomen. She didn't have any scars. She did have bowel sounds. She was soft, but she was very tender to percussion and palpation, especially in the right lower quadrant with maximal tenderness at McMurray's point. Pelvic and rectal exam were performed in the ER, so I didn't repeat them, and those were abnormal. Otherwise, exam was normal.
No chandelier sign. Didn't hurt lateral cervical motion. She didn't have a lot of tenderness?
I didn't do that.
Okay.
So.
But the ER, did you talk to the ER docs? What did they think?
It was lateral cervical tenderness. So they said no tenderness.
Good.
Yeah. So they did do imaging, and they saw a thickening at the base of the appendix, measuring 1 centimeter at the base to 4 millimeters at the tip.
The ultrasound or CT?
The ultrasound.
Ultrasound, okay.
And they didn't see any fat stranding, but she's very thin. She has no fluid collections, and they actually suggest a CT if clinical exam is not suggestive of appendicitis.
Do you think we need to do that?
I do not think we need to do that.
Okay. Go ahead.
Her labs, her Chem 7 was essentially normal. CBC was significant for a white count of 14.6, and her hematocrit was 39. Platelets were 197. So this is a 17-year-old woman with symptoms and signs and imaging consistent with acute appendicitis. The differential also includes ovarian torsion, Meckel's diverticulum, Crohn's disease, atopic pregnancy, but those things are less likely, especially with her history and onset of symptoms.
So what's your impression? Overall, I mean, she's got a differential, but what do you think her diagnosis is?
I think she's got acute appendicitis.
Okay.
So I think that we need to start preoperative antibiotics. I think that we should make sure that she doesn't eat anything before we go to the operating room, and I think she needs an open appendectomy.
Okay. Ann, did you see her?
No, I haven't seen her yet.
Okay. Did the other students see her? Do you know?
The other
medical students?
Yes, they have.
Yeah, good, great. So what do you think the most sensitive retinitis is?
I think the most sensitive sign is tenderness to percussion.
Yeah, just light percussion. So when you tapped over there, over McBurney's point, over appendix,
shoved me away and pushed me.
Yeah,
out
so
of
it
the
really
way.
hurt her a lot. Yeah. You speak Cantonese?
I do.
Yeah? Good. Sure.
That's Mandarin.
And do you have any questions?
Yeah, I was just curious if you had tried any other physical exam findings that might be pertinent for her case, any rebound tenderness that you'd found.
I tried the leg raise, and that was negative, and I don't remember what that was called, so I have to go look that up later.
So do you remember any of those? Any of the other adjunctive physical diagnostic maneuvers you can do? The appendicitis that help you figure out where the appendix is? Is it anterior? Is it retrocecal?
I don't remember all those maneuvers. I do remember that if you do some sort of leg raise that you can elicit pain, but I think she was so upset with me after I had percussed that she didn't really want me near her anyway, so
right. So if you've got a retrocecal appendix and the appendix is sitting behind the cecum in the retroperitoneum, and there's a muscle right there underneath it, right? Mm-hmm. You remember what that muscle is?
The psoas muscle.
Psoas muscle. What's the psoas muscle do?
It pulls your hip up.
Yeah, it flexes a hip flexor, right? Mm-hmm. So if you stretch that muscle backwards or extend her at the hip and cause tension on the psoas muscle, sometimes that can be a sign or known as a psoas sign. Lay them on their side and stretch their leg, they'll really hurt. Because sometimes a retrocecal appendix, because it's not anterior, will do that. Okay? The presentation is not as classic as this, and it can be delayed, and it can be ruptured and abscess back there.
Oh, wow.
And do you have any other questions?
Yeah, I was just curious. I know that you started preoperative antibiotics, which I think is a great management strategy. Your patient is going to surgery, and we noticed kind of a trend in her vital signs that she was getting a little bit more tachycardic, her blood pressures are dropping. What kind of management tactics would you do in that situation to help out your patient who's going to the OR?
Thank you for reminding me. I think we should definitely start some IV fluids, maybe some lactated ringers.
All right. Particularly in an elderly patient, right, with vascular disease. You don't want them to have an anesthetic drop their pressure when their blood volume, they're hypovolemic, because they'll crash, right? Okay, very good. So do this. Anne's in a hurry. She's running for another emergency. You got 30 seconds to get your point across. Okay? You're on the spot now. Can you handle that?
Sure.
Okay, 30 seconds. Tell her.
Hey, Anne, I have a patient. She's 17 years old. A woman came in with abdominal pain. She has been having pain in her right lower quadrant, no periumbilical pain, hasn't been eating, has flatus. Physical exam. Her vital signs are actually normal right now. I can give you those numbers when you have a moment. And exam was significant for a soft but tender belly. Imaging shows shows an inflamed appendix. So I think she has acute appendicitis.
Perfect. Very good. Excellent. So you can see whether it takes 7 minutes or 30 seconds, she hits the same highlights. What the patient complained of, what the history was, what her findings on exam were, what she thought she had as a diagnosis, and what we need to do. And really, when we document in the chart, so-called SOAP note, S for subjective, the story, O, objective, the things we find out that are irrefutable data, whether it's the vital signs, the physical exam, the lab test. A, assessment. That's what you think what's going on. And P, the plan. So we break it down into those 4 essential items, regardless of how robust you fill in the blanks. So that's how we do things. We're making rounds, whether it's formal presentation again or whether it's boom on the fly.